Yep, we're good to go.
Thank you. All right, so in the same way as the hearing, we are a little bit more flexible with visual eligibility for our services, again, knowing that someone with even a functional vision loss, progressive, cortical visual impairment cannot rely entirely on their hearing to compensate. So we have this, and again, I'm going to explain more of this to you with some slides coming up. So to understand visual impairment, you kind of have to understand the visual system, which is very similar to the auditory system, in which it's a central nervous system process. If the eye is working and the nerve is working, but the brain is working, the vision is not working. And the analogy that you see often with this is the fact that back in the days when we actually had video cameras instead of iPhones, if a video camera was taking an image and there was a cord connecting the video camera to a monitor or TV set, the place where the image actually is seen is on the TV set. That's the equivalent of the brain. So basically, just like in hearing, all the pieces have to work for a person to get reliable information from that sensory system. And that's kind of important to know, because once you start looking at what a visual impairment actually is as opposed to a eye condition, it kind of helps explain things a little more. So don't worry, there's no quiz about the eye and all the pieces of it, but the eye has so many pieces of it play a role in vision, and things that happen to any of the pieces will have the potential to impact vision, but not all the time. There can be some conditions that may make the eye look different, or maybe it's the degree of difference in the retina or the location of the difference or the injury in the retina. For example, that would make someone be visually impaired as opposed to just having an eye difference. So that's something to keep in mind. Any of the parts of the eye that are either injured or formed differently at birth can impact the clearness or the field of vision. And so when people work with children who have visual impairments, the first thing we insist on is that the child has been seen by some sort of an eye doctor, either an optometrist or an ophthalmologist. I do vision evaluations, not for Project REACH, but through early intervention, and that's really a hard and fast rule for us. I've gotten referrals for people who are concerned because their child's sitting too close to the TV. Well, as a teacher of the visually impaired, there's no way for me to know if the child would have that problem solved by wearing glasses, because I can't look inside of the eye and I can't take those measurements or look at the health of the internal eye. So the health of the internal eye is always the first step to trying to determine if a child has a vision concern. So when we talk about visual impairments, actual vision impairments, there's really two types. There's blurriness of vision, which is the acuity loss we mentioned before, with those numbers that you remember, like 20 over 20 or 20 over 200. Those are words that describe how blurry something is. And we have visual field loss. Those are basically the two ways a person could have visual impairment. Many different eye conditions can lead to those types of impairments. So when we talk about visual acuity, it's probably the easiest one for most of us to understand. It's something being blurry. You may hear people say, oh, I'm legally blind without my glasses because I'm very farsighted or nearsighted or whatever. That's not possible. Legal blindness happens when your vision is reduced in field or clearness with your best correction. So it's improper to say that you're legally blind without your contacts or your glasses. However, as a person, I'm extremely nearsighted. My focal distance at this point without glasses, since I'm also now having all the issues that come with vision as you get older, I have a focal distance without my glasses of 2 to 3 inches. That's the only place I can focus my vision. But I'm not visually impaired because my glasses do everything else I need them to do. This level of blurriness, like I mentioned, the degree of blurriness that you're seeing here would probably be the equivalent of about 20/70 vision. That level of blurriness is measured by interactions with the eye doctor and the famous letter chart. That's how doctors will get a reading and know whether or not what level of blurriness a person has. You can't really tell by just looking in the eye, but when we're talking about little kids and those who don't necessarily tell us real clearly what they see, doctors can kind of do a best guess. If the area of the eye called the macula, where we all see the best, is injured, we can guess that a child probably won't have vision any more clear than 20/200, only because that's the spot in the eye that sees the most clearly. But again, it's a guess, and as children get older and can better tell us what they see, we may know better. So that's visual acuity loss. The other way that people can have a visual impairment is through the visual field loss. And we usually look at 3 types, which we will look at in just a second. Peripheral field loss, central field loss, or 2 words that can be used interchangeably, scattered scotomas or islands of vision. So basically a peripheral field loss is what you would see if you held your hands in C shapes in front of you and put them to your eyes and kind of started looking through that little tunnel your hands are creating. You may have heard of peripheral field loss called tunnel vision. That's another word for it. And this is a very, this is the type of vision loss that someone with Usher syndrome would have, and we'll look at that in a minute. So that's usually caused by either tears in the retina around the edges or a condition in which disease over time starts to damage the retina from the outside in. So that's a peripheral field loss. Central field loss is what it sounds like. It's when you don't see clearly in the center. I don't know if any of you have elders in your life with macular degeneration, but this is what macular degeneration does. This picture is a little bit misleading because the edges of the picture, which are still visible, look fairly clear in this pixelated picture. But when the central field loss occurs, it occurs because of either damage, complete damage to the macula, which we've discussed, you know, as with macular degeneration, or some very specific injury to the optic nerve or brain. And usually what that means is that clear part of vision has been injured. So people do get to see peripherally, but the image is not clear because that's not where clear human vision lives. So people who do have the central field loss, they do have some vision, but it's going to be blurry. And it's interesting, if you meet someone who has a central field loss, they see best by not looking at something. They see best by looking next to something that they want to see. And often people might mistake this for lack of attention. when it's actually the child trying to accommodate and pick up anything possible visually. When folks get older, I had a professor in college who had this kind of vision loss, and he had learned over the years that people think that he is ignoring them when he doesn't look at them. So he, says, I look at people while I'm talking to them, but if I really want to see what they're doing or what they're wearing, I look next to them, and that's what works best for me. So if you ever see a child kind of looking in that manner, kind of next to you, it might be interesting to find out if they do have a field loss and they've just figured out how it works for them. So the other type of field loss are either scattered blind spots, and the other word for a blind spot is a scotoma, or islands of vision. And it's about the same thing. The difference is how much vision you have. If you have mostly vision and some spots are missing, they'll usually call that a scotoma. And if you only have pieces of vision available, they might call it islands of vision. I've seen it both ways. So, and this can be caused by injury to the optic nerve, injury to the brain, and even in some cases, depending on the type, something like cataract or very specific. I haven't seen it much with retinal injuries, but it would certainly be a possibility. So basically, those are the ways that a person could actually be considered visually impaired. The majority of kids who have an eye condition are not visually impaired. So, for example, I already let you know that if you're farsighted and nearsighted, you can't be legally blind without your glasses. That's not how visual impairment is measured. Same thing with an eye turn. And so eye turn, the fancy word for it is strabismus, interpreter S-T-R-A-B-I-S-M-U-S. It's a type of eye turn problem. It does need to be attended to, because if your eye is constantly turned, it will cause the eye that's not being used to develop amblyopia, A-M-B-L-Y-O-P-I-A. And the word we often hear for that is lazy eye. Basically, the brain doesn't want to see two pictures. It wants to see one picture. That as we are growing up, we learn to use the picture from each eye, fuse it together in our brain, and attend to a single image. Well, if you have an eye turn, that's not possible, and the brain will either shut down the eye that's not as strong, or you may see kids who have a constant eye turn, and they take turns using each eye. Taking turns is a good thing, because that means there's vision in each eye. But generally, just because a child has an eye turn does not automatically mean the child is visually impaired. This is one of those examples when we would have to look at the child's function. Is the eye turn preventing them from using their vision to learn? And if the answer is not really, then they probably would not be classified as visually impaired, even though they might need treatment from the eye doctor. So I hope that's clear. All right. So when we talk about syndromes and other causes for vision loss in kids who are deaf and hard of hearing, I'm pulling up some data now. I mentioned that every state has a program for students who are deafblind in terms of technical assistance. One of the jobs of those groups is to develop a census. It's a required child count that's reported anonymously, but it allows us to get some statistics and numbers, which is really critical when you talk about developing services. We need to know what is the group out there and what kind of services can we anticipate them needing, what kinds of supports do we need to give their families and their teachers. So in 2011, that child count, one of the biggest causes of a combined vision-hearing loss was prematurity. But charge syndrome we'll talk about in depth. Prematurity we'll talk about in depth. CMV stands for cytomegalovirus. It's not a syndrome. It's a disease that can impact a pregnant mother, and that can cause both hearing and vision concerns in her child when her child is born. And that's the same thing as congenital rubella. That's another condition that can happen prenatally. Surprisingly, we still do have cases of rubella, also called German measles in the U.S., which, I mean, the vaccines developed have pretty much helped to eliminate that, but with people moving in from different countries, I still see students with congenital rubella. Some of the other syndromes would be Down syndrome, which is often comes with either vision or hearing loss and occasionally both, and then Usher syndrome. We're going to talk about Usher syndrome in detail farther ahead. So what you see is that really syndromes are one of the reasons why people have vision or hearing loss, but there's a lot of causes both prior to birth, during birth, and then adventitiously that can impact a child, like severe head injury. But a lot of times, actually, the causes are pretty complicated. The greatest cause, according to the census, of combined vision hearing loss are other hereditary syndromes. I could show you the list of all the syndromes that can cause combined vision hearing loss, but it's really quite mind-boggling. The ones that I see the most that you haven't seen in the previous slide are the trisomy syndromes, 13 and 18, cocaine we see occasionally, and I mean, really, there's quite a number of them. And sometimes we've had some children who are the only child with their known syndrome. So it's kind of hard to put your finger on. Some of the syndromes often come with additional disabilities. Some it's just the vision hearing. So lots of prenatal complications, lots of postnatal complications, and even in this day and age with genetic research, sometimes no causes can be found. So a lot of families really, that's difficult for families because many people would like to connect with others who, you know, in their words, have a child like their child, and sometimes it's hard to do when they can't put a label on that. So if that's the case, we at Project Reach try to connect families with other families just based on what we know about them, what their child is like, what their child likes to do, what their family likes to do. We'll try to make those connections, but I do think it's a difficulty for people. So as I mentioned, let's move on forward and get through this. We're going to talk about 3 specific causes today, and those will be charge syndrome, Usher syndrome, and prematurity. I chose charge syndrome because it is the fastest growing syndromatic cause, hereditary cause that I've seen. It's really kind of, for lack of a better word, exploded. I think it's more visible and people are more aware of it than they used to be, and I think that's one reason why we're seeing the numbers grow exponentially in Illinois, or at least our knowledge of those numbers. We'll talk about Usher syndrome. That was a specific request, and that's important to talk about because its progress is different, and children may not be identified as having a vision concern right away, and that can lead to some difficulties for people. And then finally, we'll talk about prematurity again because it's, again, a growing cause of vision impairment for kids who are deaf and hard of hearing. And it also talks about a condition I want to make sure you guys know about called cortical visual impairment because it's different than all the others. And it's one that, if identified early enough, there's some specific therapies that can help. So I wanted to make sure to cover that. So let's talk a bit about CHARGE syndrome. Basically, this is a condition that was identified in 1979 prior to the Human Genome Project. In 1981, they came up with 6 diagnostic criterion that made up that CHARGE acronym. Coloboma stands for a defect of the eye. Sometimes you'll hear it called a cleft. So there's a piece of the eye missing. If you've ever known someone who has a keyhole iris, so you look at their eye and the place where the colored part of their eye has a little slit cut out of it, that's an example of a coloboma, one that we can see. But those kinds of pieces missing can happen in the optic nerve head, in the retina, the macula, and depending on where that coloboma is will greatly impact the degree of vision a person has. Some people with CHARGE syndrome, their colobomas are in the periphery of the retina, the area of the retina we rarely use, and they're really not visually impaired. Sometimes it's more significant. So again, the coloboma, the heart defects, atresia of the canoa is basically blocked or narrow passages. Kids have great difficulty breathing and are usually identified immediately upon birth. The R in CHARGE for a long time stood for retarded growth and development, and back in the old days they would even say mental retardation, but that was proven not to be true. And then genital anomalies, or sometimes you'll see gastro anomalies, that was the G in CHARGE, and then ear anomalies. You might hear people refer to kids with CHARGE having a certain shape of ears. And basically what happened was, as more data was collected and more people were given this, I'll say, tentative diagnosis of CHARGE, the Human Genome Project came along and actually identified a gene, a specific gene that causes CHARGE. And what they found was people previously identified with CHARGE syndrome actually may have had another type of syndrome. There were several in the mix. A big one is something called Kabuki syndrome. You got to love the way they name these things. Now you feel kind of offensive saying them, but basically there was a specific facial shape and lack of expression that reminded the researcher of Kabuki theater in Japan, the kinds of masks that people use. But basically, Human Genome Project came, they identified the chain, and what they found now is that really there are 4 markers for CHARGE syndrome. The coloboma is still there. That's one that most kids with CHARGE have in some format. The canal atresia or stenosis blockage is still there. These kids are very likely to have trachs. Many kids have trachs at least for some part of their life. They changed the E in ears to CHARGE ears because sometimes it comes with kids being deaf or hard of hearing, and sometimes the ears are just different. They may be misshapen or may have no cartilage, and hearing loss may not be an issue, but there's usually something going on with their ears that's a marker for the syndrome. And the final C is cranial nerve dysfunction. This is a big one. These kids have a lot of stuff going on, and what they found with this continued research is that a lot of kids with CHARGE syndrome can't smell. I think it's up to, they're still trying to figure it out, but maybe up to 40% of kids can't smell. Some of these kids have real issues with trigeminal nerve pain, migraines, things like that. And most of these kids, I would say, are just different in their neurology. They could overreact or underreact or have some other kinds of neurological differences. So that's not uncommon for kids who have CHARGE syndrome. So the medical issues are kids with CHARGE have frequent medical issues from birth on, and they require lots of the supports that you can imagine. And there's a difference in opinion about whether or not children with CHARGE have a dual diagnosis that may be including autism or obsessive-compulsive disorder and other neurological conditions. Some people see it as an actual secondary condition. Other people say, no, it's really just a function of charge syndrome. They may have some behavior similar to children with autism, but a second diagnosis of autism is not appropriate. So you may see it go both ways. And quite frankly, some families, you know, for one reason or another may want or not want a diagnosis. You know, if they feel like a diagnosis of autism is helpful for them in seeking other services in the school or outside of the school, then they may choose to pursue that. But I've seen families with strong opinions either way, and that's, of course, something that they'll do to the best interest of their child. So basically, we mentioned that kids with charge syndrome may have acuity and field loss because of, you know, about the coloboma. They also have, as they go on in life, a higher incidence of cataracts. They may have retinal detachment, which, if you think about it, if they have the coloboma on the retina, so there's a piece of the retina missing, so basically there's a hole in the retina, there's more places where the retina could become dislodged. Could be if there's a fall or, you know, hitting the head with a ball during gym or whatever. So retinal detachment is something that they do monitor for students who have charge syndrome, especially when they have the colobomas. And there's a little bit more, excuse me, consideration that a child may also have cortical visual impairment, which we'll talk about in a minute. And so they may have visual processing issues. But the most common visual field loss for someone who has charge syndrome is an upper field loss. So instead of looking like this is what the child with charge would see. You'll often see kids with charge syndrome tipping their head back and looking up. And this is just important to note. If we can document where their field loss is, we can be more careful about where we put items in their, you know, if they use a communication device. If we're signing, we can be very careful about where we place signs and the width of the signs we're using. If we're speaking to them, we can be sure to speak within their visual field in case they compensate with some lip reading. So this is probably the most common field loss, but again, it's very important that each child be assessed individually. All right, I'm going to start zipping. Our next syndrome we're going to talk about is Usher syndrome. And it is the most common single condition that involves both hearing and vision problems, but that as I said, when children are young, they may not know they have Usher syndrome. Usually when you look at the birth through old age population of people with deaf blindness, Usher syndrome is near the top. And I think the research shows like 3 to 6% of people identified as deaf and hard of hearing may have Usher syndrome, but those numbers are going to change because of the Human Genome Project. What's important to remember is that Usher syndrome comes with it an eye disorder called retinitis pigmentosa, which is, you'll see, called RP all the time, and vision worsens over time. So it's basically an eye disease where the rods and cones in the retina are beginning to deteriorate. And so at first, people are going to notice that they're having a hard time seeing in the evening. People who have not yet been diagnosed, some of the first symptoms are, I'm riding my bike and I have to get home before dark. A very famous person who is deafblind with Usher syndrome said he went to a Catholic school and he got in trouble because they were sledding and twilight came and he kept knocking over the nuns because he couldn't see them anymore. And so that's how he figured out that he had something going on. So that night blindness is the first condition. Eventually, they're going to have peripheral field loss. We already looked at that, the tunnel vision. Sometimes color vision can be affected, but it's important to note that total blindness rarely occurs. Usually people have some vision. But of course, parents usually respond with a lot of shock. Their child already has a hearing loss. They're either deaf or hard of hearing. And so it's a very difficult process for parents, especially back in the day when they usually didn't figure out that a child had Usher syndrome until they were a teen. And so nowadays there's earlier diagnostics that are helping kids get identified more earlier, but they're electronic diagnostics or genetic diagnostics. Usually you can't just look at a baby and go, oh, that kid has RP. Usually the change in the retina hasn't occurred yet, so you can't see it just by looking at it. They basically do a test called an ERG, which is the equivalent, I would say, of a otoacoustic emissions test, where they're testing the cells in the retina like they might test the cells in the cochlea. So that's how people are being identified more early now. And so there's always been a couple of types of Usher syndrome, 1, 2, and 3, and now they know why type 1 was different for some people or another. Sometimes type 1 came with dental problems and sometimes it didn't. Well, now they know that all these different genes might cause what we used to call Usher syndrome type 1. The other genes may cause what we used to call Usher syndrome type 2. And they still do call it that. It just helps explain why there's these differences among people who technically have the same condition. So if you have Usher syndrome type 1, you've been deaf from birth with a corner audiogram. Type 2 folks were hard of hearing, and often back in the day were educated with hearing aids in an oral classroom. The people with Usher syndrome type 1 were identified pretty young as folks who were deaf, might be like age 2 back in the day, and were probably more likely to be educated in a school for the deaf. Nowadays, of course, it's a much different picture with people with identification and newborn hearing screenings and things like that. And parents are making different choices than were available to them before. But that's the difference kind of in the hearing for those different types of Usher syndrome. There's often been balance issues, more in type 1 and then progressively in type 3. Type 2 didn't have balance issues, and that's still not an issue. And then when we look at when RP happens, basically the RP starts to happen more quickly in type 1 than in type 2 and type 3. So basically, as I said, these children who have Usher syndrome are getting diagnosed early as6 months because of the newborn hearing screening. If people, if there's not a clear reason for a child to be deaf or hard of hearing, there are some centers now, especially in Chicago, that will automatically do the electronic testing to see if they have Usher syndrome, because parents may want that information as they move forward with choosing communication system. So that's one reason. It's also important because that if kids aren't identified, a gradual decrease of vision may go unnoticed, and they may still be driving or they may be crossing busy streets. It's helpful to know a diagnosis of Usher syndrome shouldn't limit a person's choices, but it might be wise to inform a person's choices. Knowing that you're going to be blind at, I shouldn't say blind, knowing that your vision is going to decrease over time and maybe won't be your most reliable sense by the time you're 40 or 50 doesn't prevent you from doing any vocation until then. So people can get some counseling and make plans that they want to make. And I think the most important reason for early identification is there are treatments being talked about every day. So parents may want to know about that, families may want to know about that, and see what their options are for treatment for the vision concern. All right, so we're going to jump into prematurity. Again, just an expanding population in programs for kids who are deafblind. The vision conditions do include retinopathy of prematurity and cortical visual impairment. However, the retinopathy of prematurity, also called ROP, is caught early and treated well, there may be very few visual implications. There are kids who had ROP who are not visually impaired. So often, though, it will come with a bit of nearsightedness, which may be fully treated with contacts. But if it does progress, there could be damage to the retina. But really, the retinopathy of prematurely is being treated so much better in the NICU than it was before. It's not as big an issue. The bigger issue now is cortical visual impairment. And basically, that's the inability of the brain to process visual information. This varies dramatically from child to child. And it's caused by many things, not just prematurity, but basically anything that could injure or any difference in brain structure from the cellular level to the structural level can cause cortical visual impairment. And so the diagnosis and treatment can be kind of complicated. There are other conditions like untreated farsightedness, autism, and CP that impact early vision development that aren't cortical visual impairment, and they're kind of hard to weed out. But usually the diagnosis is made by medical evidence, and you can look and see if the child had an intraventricular hemorrhage or any kind of injury or brain difference. But you can also make diagnosis by symptoms. So the eye doctor would say the child's eyes are okay, but they do not seem to use their vision. That would be another way to get that diagnosis. Now, simulating CVI is difficult to do because it varies widely from child to child, but I'm going to try to do it. So those of you who feel comfortable doing it, unmute your phones because I want some feedback from you. I'm about to show you a picture, and in this picture, I'm going to show you something, and I want you just to say your name when you think you know what it is. Don't tell me what it is. Say your name when you think you know what it is. So if you've got your phone unmuted, here's the picture. What I'm going to do is start giving you hints as to what this is. The same way that a child with cortical visual impairment may use, for lack of a better word, hints or evidence to figure out what they're looking at. So I'll tell you right now, you're looking at just one thing. Not a group of things, it's just one thing. And it's something that, maybe. So who heard it? Who said it?
I think I see it, Michelle.
Okay. It's one thing. It's something that we saw in Chicago for like years and years. There was this big craze
a cow.
For a while.
Yeah, a cow. It is.
Okay. So okay. All right. Okay. For those of you, someone already told us what it is. It's a cow.
Wow. Cool.
Let me show you. Now here, let me show you the other picture. Right now what I've done is I put red in the area where the cow's face is. For those of you who don't have it yet, let's go back. Here's the red where the cow's face is. And then to the left going off screen, you see one ear. There's another ear on the other side, and the cow is standing in front of you sideways, but turning its head to face you. Does everybody see that?
Yeah, I see it.
Yes, I see it.
I wanted you to suffer. I wanted you to be agonized with not knowing what this is. Because quite frankly, it's not that you can't see it. It's right there. You just didn't know what it was. And that's what it's like for kids with cortical visual impairment who are being asked to use their vision. It's hard. It's tough. For those kids who have enough cognitive and language ability, they say, it's too hard to use my eyes. And I think that it's important for us. I can't, unless you allow me to injure your brain, I can't really simulate cortical visual impairment. But the fact of the matter is, I think it's important for us to struggle a bit with this task so that we know how hard it is, what we're asking kids to do. So that's why we do that. And so there's basically, there's a theory about vision that some of it, that where we use our macula and get our high, clear vision, it goes in one pathway, and then our peripheral vision, where we see things that move real quick, go through another pathway. Basically, one is the, for lack of a better word, the thinking pathway. The parvocellular is like the thinking pathway where we read, where we see people's facial expressions and interpret them. And then we have the magnocellular, which is our survival vision. The theory is that kids with cortical visual impairment, their learning vision has been injured, but they often have that survival vision, which explains some of this. So depending on where the injury of the brain is, it may affect acuity, it may affect field, it always affects understanding, but it varies from person to person. So some of the typical behaviors that we know kids with CVI have is they don't look right away. It takes them a while to figure out where to look. They don't have a lot of visual curiosity. They'd rather see something that looks familiar. Wouldn't you? If every time you looked at something you had to say, well, what the heck is that? You'd rather look at something where you go, oh, yeah, I remember that. That's that cow. I saw that before. Their vision may fluctuate in different environments, not because they're fluctuating, but because the environment is either supporting or not supporting what they can do. And they may have color and pattern preferences, extremely interested in lights. These are kids that you have a hard time redirecting sometimes. But they have difficulty with visual complexity. They do sometimes see things better when they're moving or when they are moving. I've seen kids run down a hallway and not hit a single obstacle, but when they're standing still, they can't reach for something in front of them. And then the big issue, and this is huge, when you talk about kids who maybe are working on oral habilitation, they can't look and listen at the same time. So they may close their eyes when they're listening, and they can't reach and look at the same time. They may look, figure out where it is, and reach. So that's basically cortical visual impairment. Very, I won't say very common in kids who are premature, but it is a high-frequency vision issue for kids who are premature. So we're over time. Let me ask real quick if anyone has any questions.
Okay. Well,
right.
Let's move to the final slides then.
All right, here come your quizzes again, but since we'll be finishing up, I just want to say thank you very much. If you ever have, there is a resource page that's coming to you, and again, that has information about how you can contact me, and then a bunch of other resources for some of the things we discussed. So you're sending that, Carrie, right?
Yep, I sent it off.
Okay, thanks. All right, so let's go back to the questions. Question 1, a person with deaf blindness is defined as a person who is totally deaf and totally blind. True or false? Carrie, is anyone just on the phone now? Do I need to repeat things?
Amy's still just on the phone.
Okay, Amy, question 1. A person with deaf blindness is defined as a person who is totally deaf and totally blind. True or false? Melissa, you just sent me an answer, it looks like. Oh, actually, no, I forgot. I'm Carrie. My fault.
Mm-hmm. Okay. Question 2.
All right, number 2. A child with an eye turn is always visually impaired. True or false? A child with an eye turn is always visually impaired. True or false?
Okay, question 3.
The most common cause of deafblindness in children in the United States in 2011 was 1, Usher syndrome, 2, prematurity, 3, head injury, 4, a variety of hereditary conditions, or 5, none of the above. The most common cause of deafblindness in children in the U.S. in 2011 was 1, Usher syndrome, 2, prematurity, 3, head injury, 4, a variety of hereditary conditions, 5, none of the above.
Okay, question 4.
If a child is born prematurely, they are at greater risk for which visual conditions? 1, nearsightedness, 2, retinopathy of prematurity, 3, cortical visual impairment, 4, 1 and 2, 5, all of the above. If a child is born prematurely, they are at greater risk for which visual conditions? 1, nearsightedness, 2, retinopathy of prematurity, 3, cortical visual impairment, 4, 1 and 2, 5, all of the above.
Okay, question 5.
Retinitis pigmentosa is 1, a condition that affects the nerve of the eye, 2, easily identified by looking at someone's eyes when they are born, 3, a condition that decreases vision over time, 4, all of the above. Retinitis pigmentosa is 1, a condition that affects the nerve of the eye, 2, easily identified by looking at somebody's eyes when they are born, 3, a condition that decreases vision over time, 4, all of the above.
I'm just missing, there we go. Okay, next.
Okay. Last one. Because deafblindness is rare, small states have few deafblind resources for schools and families. True or false? Because deafblindness is rare, small states have few deafblind resources for schools or schools and families. True or false? And I just want to thank people for doing that extra survey, the evaluation of the program. When you work for a federal grant, if you don't get evaluated, it never happens. So your feedback is greatly needed and also very appreciated. I would welcome any suggestions on how to do a webinar better since this is my first one, so thank you.
Excellent. I'm going to go ahead and stop the recording.